for June the 29th of 2021. Let me pull up the presentation. Okay, there we go. And I'm gonna start the slideshow. And as we begin, as usual, wanted to begin by saying, that we really have no financial disclosures to report from myself or any of us in our research team related to the contents of this presentation. The topic for today is opioid use disorders and pain. Specifically, like how do we manage pain, both chronic and acute pain, in individuals who may have opioid use disorder and who may be on medications for opioid use disorder. Sometimes that can become a bit tricky, a bit challenging. So I wanted to present sort of the basics of some of the basic principles of doing so. So we're going to start by really talking about just the comorbidity, right, of opioid use disorders and pain, and then really go into strategies to manage pain for both chronic and acute pain, as I mentioned. And throughout all of it, I think one of the points, and it's one of the objectives there, is that for patients on medications for opioid use disorders, right, they still may need pain control, right? And it becomes ethically and clinically and medically important for us to make sure that the pain is well managed. And so I think one of the trick is, how do we do that responsibly and safely and effectively? So hopefully this will start to build some framework around that, beginning with prevalence, right, as for our first objective. So you can see that a number of studies have looked at this, kind of the comorbidity. What is the percentage of patients with opioid use disorder who also have chronic pain? And I think one of the earliest attempts done was in 2003, which placed that comorbidity as about 37%. In other words, about a third of patients with opioid use disorders in that study also had chronic pain. But you can see kind of that number rising. And most recently, the most recent study is the study done by Eiling Sel from California. And their group found that about almost 2/3 of patients with opioid use disorder also met criteria for chronic pain. So it's significantly higher than general population, right? We often talk about in general population about 10%, which is still, of course, not insignificant, but we talk about 10% of people may meet criteria for chronic pain. But here in this study, in patients with opioid use disorder, that number was substantially higher. Majority, in fact, had it. So this is really looking at it from that study, where they looked at over 5,000 adults who sought treatment for opioid use disorder. And really what they found was, again, about 2/3 also met criteria for chronic pain at some point in their treatment. But if you look at the kind of the red bullet, for 40% of patients, the pain actually came first, and opioid use disorder maybe came after the chronic pain diagnosis. For about 15%, it was unclear what started the cascade or what came first. And for another 10%, so it was really only 10% of that 5,000 adults for whom the opioid use disorder started first, and then chronic pain was developed, right? So to me, that really highlights the importance of how are we managing chronic pain, right? How do we manage chronic pain responsibly, really ensuring that we're maximizing all of our non-opioid medications, all of our non-pharmacotherapeutic modalities that may be evidence-based or evidence-guided, such as acceptance and commitment therapy or CBT for pain, or physical therapy or acupuncture, myofascial work, right, trigger point, kind of really maximizing all of those. And if opioids are prescribed, really making sure that we're prescribing appropriately, responsibly, monitoring patients closely, right? Because really it was 40% of the patients out of that group for whom the chronic pain came first, opioid use disorder developed subsequently. Perhaps unsurprisingly, that 40% who started with chronic pain had high rates of other psychiatric illnesses, other health conditions, but that 10% who had opioid use disorder first tended to all just have more severe substance use disorder. They had other substance use disorders or things like HIV and hepatitis C. So next, I'm gonna go into kind of the next big topic for this presentation, which is acute pain management. And this is public domain art shared by individuals with pain. which I think I just find poignant. We'll start with a vignette, with of course identifying details change, but based upon a patient that I saw when I was a fellow in addiction psychiatry. AN is a 45-year-old female, status post a shoulder surgery. She has a history of opioid use disorder and was previously treated with methadone twice. She stopped treatment and relapsed both times. Every time she went off methadone, she returned to illicit opioid use. Right before the surgery, she had been using heroin half a gram 2 or 3 times a day by smoking it. Said she wasn't injecting it, really smoking it. And now, post-surgically, she's on morphine continuous infusion, 4.2 milligrams an hour. Plus, she's allowed a 10 milligram IV dose every 4 hours for breakthrough pain. And she last used that breakthrough bolus 2 hours ago, right? So she still has 2 more hours to go before she can request that again. But she is requesting more pain medication. She reports her pain is 9 out of 10. She's crying. She's in tears. Her vital signs are stable. And when I get to the unit, I'm told, quote, she is drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict and we don't want to worsen her condition. So let's keep this patient in mind as we go through the acute pain management section. Some commonly held beliefs. So in general, acute pain in perioperative settings is frequently undertreated, up to 60% in inpatient settings, according to some studies. We don't know the prevalence of undertreated acute pain in patients with opioid use disorder, but many experts think, and makes sense, that it's even more likely that acute pain may go undertreated in individuals who have an identified history of opioid use disorder. And studies show this big gulf, right? Where addiction is seen by healthcare professionals as, quote, primarily a social problem that requires law enforcement rather than a health problem that requires prevention and treatment, right? And patients with opioid use disorder, substance use disorders are often seen as manipulative. On the other hand, I think the same study by Van Boekel found that if you talk to individuals with the opioid use disorder, their big fear is that my pain will be undertreated. And the big fear of the providers, the clinical team, is manipulation, right? So there's a big gulf that you can already see how that would complicate things. So this is the suggested approach. This is kind of really the approach we recommend taking. First of all, accept the patient's self-reported pain. We know that pain behaviors vary widely. There may be a gender effect, there may be a cultural effect, there may just be an individual effect, right? Shaped by prior experiences, life experiences, etc. So we want to accept the patient's self-reported pain. And vital signs, while certainly we should be looking at them, they're not extremely reliable indicator of pain intensity. So we can't just go based upon the vital signs, right? Consider the idea of, is it addiction versus pseudo addiction versus physiological dependence. So remember that addiction, the way we define it in the DSM-5, it's a chronic illness where there is a compulsive need to use the substance, right? It often leads to consequences, adverse consequences. There's an inability to stop using the substance, right? Despite all those consequences. By contrast, physiologic dependence is just a phenomenon that person has gotten used to a particular substance, right? So for example, I always like to use this example that if someone's been taking a stimulant laxative like Senna, I guess, chronically, their bowel might be dependent upon it. And if they stop using the Senna suddenly, right, they might experience constipation, right? So physiologic dependence happens not just to opioids, but to many medications, many substances we use or prescribe. And that by itself does not mean that the person has developed addiction. Pseudo addiction is quite a controversial term, actually, that came out of kind of cancer literature in the 1980s. And that's the idea that the patient's pain is simply undertreated. So the patient may display behaviors that at first glance seem problematic, but when you raise the dose and adequately treat the pain, their functioning improves and a lot of those problematic behaviors go away. By contrast, if the person has addiction, going up on the dose is not generally going to lead to those behaviors going away or improved functioning. In fact, the functioning might worsen as we keep raising the dose, right? So it's important to think about and reflect upon these as they apply to the patient. If required, do not withhold opioid analgesics for people with addictions. And I'm talking about acute pain management, right? There's generally no reliable data showing that acute pain management will worsen addiction. I think the principles, as you'll see, are very different when we talk about chronic pain management. Now, this is simply focusing on that acute pain management, right? And remember that if this patient, for example, the patient in our vignette, already has the tolerance. So they may require and be able to tolerate higher doses of opioids than other patients who may not have that baseline tolerance. And that's part of the key, right? Why is this patient needing higher doses than other patients in the unit? Because she has the baseline tolerance. And this is something that comes up for many of us often, where we may get a call from an inpatient provider saying, well, the patient's already maintained on methadone. Shouldn't that manage their pain? And the answer is no. The opioid agonist treatment will treat the baseline addiction, but will not address the acute pain, right? So keep that in mind. So now I'm going to break it down, a slide or two each. Acute pain management, methadone, buprenorphine, and naltrexone. We'll start with methadone. So say you're working on the inpatient setting, the patient comes in, needs acute pain management, but the patient is maintained on methadone. Patient says, I go to such and such clinic and I'm maintained on methadone. This is the suggested approach. You may continue the baseline methadone after verifying the dose from the home clinic. Every patient will have an OTP in which they're enrolled. And patients will be generally more than happy to tell you what their OTP is because they don't want to miss their dose, right? So you want to call up the OTP, verify the dose, and generally you may continue that dose. If the dose cannot be verified, it's safer to break up the self-reported dose in 3 or 4 times a day dosing rather than giving it all at once. A, it makes it safer, and B, splitting it up into more frequent dosing may actually help with analgesia more. So that's a good suggested approach. And plus, because methadone is a full mu agonist, if that's not cutting it, and if the acute pain management need is quite high, you may add in other short-acting opioids for breakthrough pain. You may also gradually increase the methadone dose, gradual being the key. Methadone is a tricky medicine to use, so you don't want to be making very sudden, quick adjustments. Do not administer buprenorphine, because remember, in a patient that's maintained on methadone, that dose of buprenorphine may throw that patient into withdrawals. So if the patient is maintained on methadone, please do not use buprenorphine for pain management. Patients who are unable to take their oral dose for whatever reason may be given IV methadone. But remember, if you're going to use IV methadone, you got to be very careful. And the dose must be reduced by at least a half or even 2/3 and then further divided up into 3 or 4 times a day, Q6 or Q8 hour dosing. Methadone for analgesia does do better with multiple times a day dosing and can be prescribed by any clinician with a Schedule II license. So, your providers on the inpatient side should be able to manage this. But methadone for addiction is once a day dosing, and on the outpatient world can only be done through an opioid treatment program. What about buprenorphine in acute pain management? The key here is, right, that buprenorphine is a partial mu agonist with a very strong high affinity for the mu opioid receptor and a slow speed of dissociation. And that's where the concern arises, that if someone is maintained on buprenorphine, are we going to be able to give them adequate pain control, adequate analgesia? And the answer is yes. This, again, is the suggested approach. You always want to start by maximizing all of our non-opioid modalities for acute pain management, right? So don't think about, rest, ice, compression, elevation, things all of us can advise patients on, but also things like epidurals, nerve blocks, ketamine. IV ketamine can be a wonderful agent for acute analgesia. Alpha-2 agonists, certainly clonidine, but also things like Presidex, for example, which is a parenteral alpha-2 agonist, can be a very useful tool. Next, what you want to start doing if the patient is maintained on buprenorphine, you want to start adjusting their dosing interval, right? By splitting it up into multiple times a day dosing. So for example, if someone's been taking 12 milligrams a day, they're going to do better if you split it up into 4 milligrams 3 times a day, because remember, analgesia requires more frequent doses. Oftentimes, we will also temporarily increase the dose of buprenorphine. So if someone has been taking, for example, 16 milligrams a day or 8 milligrams twice a day, Temporarily, we might give them 8 milligrams 3 times a day. Consider IV buprenorphine, which is a very effective analgesic. You may then actually also augment with short-acting opioids with high mu receptor binding affinity if needed. So oftentimes these are things like fentanyl or Dilaudid. Certainly fentanyl in street use is very unsafe, very dangerous, as all of us often talk about. But in a monitored setting, fentanyl is quite effective and actually quite safe. Anesthesiologists can titrate it very effectively and in very small increments, and consult an addiction medicine expert to help with it. Perioperatively, as I've talked about, there is a big divide where patients often fear mistreatments and providers often fear deception, right, and manipulation. And there is a lack of consensus in the field. You'll find that depending on what part of the country you are, how much experience the surgical teams have with buprenorphine, you might actually find vastly different protocols. So this is kind of the good best practice suggested approach. So I tell all my patients, right? We tell our patients that if you're going to have a procedure, no matter how minor, let us know as soon as you find out so we can be sure that you're going to be able to get adequate pain management. And then once we know, we get multi-party consent and we initiate that conversation with the surgeon, with the anesthesiologist, with the outpatient primary care doctor, right? To come up with a plan. In general, the old approach used to be, right? And I'm gonna kind of go to this. The old approach used to be that, you would stop the buprenorphine about 72 hours before the surgery. So the patient would already be withdrawing when they would go to the operating room. Then their perioperative pain would be managed using full mu agonists. Then after some time, those mu agonists would be discontinued and buprenorphine would be restarted. But there was a risk of losing the patient. Patient may never come back to buprenorphine. So we have moved away from it. And in fact, the current evidence does not support the practice of routinely discontinuing buprenorphine before surgery. Sometimes we have to for very major surgeries, but for most surgeries, what we do is actually continue the buprenorphine perioperatively at a dose of 16 milligrams or less, and then augment that, using multimodal analgesia or even those strong full mu agonists. So buprenorphine just stays on board perioperatively. This is a very good editorial that really brought this modality or this method of pain management to light, written by Anna Lamke out of Stanford University and her group. And that this is really increasingly becoming the standard of care. Finally, naltrexone in acute pain management. First of all, I tell my patients on naltrexone to carry a medical alert card that informs medical personnel that they're taking injectable naltrexone, right? Next, if someone is taking injectable naltrexone, if it's a planned surgery, or you want at least 4 weeks between the last dose of the injectable naltrexone and the surgery, because that naltrexone is going to be providing very strong opioid blocking effects. If someone is taking the oral naltrexone, that number is 72 hours. You want to give about 72 hours between the dose of the oral naltrexone and the surgical procedure. What if it's an emergency surgery? In that case, again, that medical alert card is going to come in handy. And generally, anesthesiologists are quite good at this, right? And increasingly experienced with it. The name of the game is multimodal analgesia, right? Including things like ketamine, including things like conscious sedation, or even general anesthesia will be used for pain management. Next, I want to just introduce some concepts of chronic pain management in this patient population. Again, sort of, I think, kind of a pretty poignant art by someone suffering from chronic pain, that, I think speaks 1,000 words. Basic considerations. So remember, a history of opioid use disorder. So our approach you'll see is very different compared to acute pain. Remember, I said if someone has acute pain needs, treat that acute pain, because again, it's time limited. But with chronic pain, chronic non-cancerous pain, the approach is different, right? Because it may be long-term treatment. And in fact, if someone has a history of opioid use disorders, it is in fact the single biggest predictor of aberrant behaviors to prescribed opioids. So we must be very careful in patients who already have opioid use disorder who may need pain management, right? Chronic pain management. Consider getting consultations early by consulting a pain management specialist or an addiction specialist, and use a multidisciplinary team approach. As much as possible, right? Of course, we want to maximize, as I already mentioned, all of our non-opioid medications, adjuvant medications, as well as our non-pharmacological therapies before we turn to opioids, right? And then if we must prescribe opioids, which might be the case in a small subset of these patients, be very careful. Do adequate screening, use validated screening tools such as the SOAP-R. Do ongoing monitoring for aberrant behaviors by using urine drug screens, prescription drug monitoring program, treatment agreements, right? Maybe see them frequently and make sure that you're prescribing naloxone and talking about safe storage. A little vignette now. I'll go into methadone and chronic pain. This is a 64-year-old female presented to the emergency department with dysuria. And when she came in, she was actually found to have advanced cervical carcinoma with local metastasis. And a need for pain management was identified. But there was concern was this patient had a 30-year history of heroin addiction. And providers were concerned that she would just inject right into her port. So we consulted with the cancer team, the ED team, and came up with a plan where basically we picked her up at our clinic. We started the patient on methadone because we figured that the pain management need was going to be so great that buprenorphine simply would not cut it. This is a patient who needed to be on methadone. So we started her on methadone and very, very carefully titrated her up at our clinic. Meanwhile, the oncology team and the palliative care team placed her on additional short-acting opioids for breakthrough pain. And we collaborated very, very closely. And the patient actually did very well. The patient was with us for about 3-4 years, until she passed, and, never had a relapse on illicit opioids, and felt as if her dignity was preserved. So the take-home point is that for most patients with opioid use disorder and chronic pain, we think about buprenorphine, as we'll see in the next couple of slides. But in some cases, in some select cases, the patient's opioid dependence may be so great, or the pain management need may be so great, that the opioid dependence may be better treated with methadone maintenance, because they may just need that much analgesia. But for most patients with chronic pain and opioid use disorder, think about buprenorphine. This is a vignette. Again, these are all patients that we've seen with identifying information change. 55-year-old female came in for addictions treatment. She actually came to our clinic, said she had a 12-year history of chronic pain after an ATV accident that led to a pelvic fracture. And over time, her outpatient providers had built up her opioid doses, and she was now prescribed 300 morphine milligram equivalents a day. And she was running out early. And there were aberrant behaviors. She would run out early. She would buy them off the street, go to multiple providers. And she was reporting problems in marriage, work, relationships. She was reporting worsening depression and anxiety, and said, I'm taking all these opioids, but I have more pain than ever. My pain is worse than ever. I have pain all over. We thought she had developed opioid-induced hyperalgesia. So we simply placed her on buprenorphine, 4 milligrams 3 times a day, a whole lot safer. She actually did really well on it. She had improvements in pain. She reported being happier, was functioning better at work, and said, quote, I have my life back, right? So buprenorphine, think about buprenorphine, that a subset of patients, in fact, I would say a large subset of patients who have chronic pain and a history of opioid abuse or opioid use disorder, actually it'd be a whole lot safer and may experience reduction in pain and abuse liability simply by treating both the opioid addiction and the pain with buprenorphine maintenance. Generally, for these patients, you do want to dose them more frequently, 3 or 4 times a day. It may also mitigate opioid-induced hyperalgesia, so that may be an additional benefit. These are just some reasons why buprenorphine might be a good option for a frontline analgesic. For reference, this was a classic study, came out about 6 years ago, 5 or 6 years ago, done out of California at a pain clinic. And they took patients who were on very high doses of opioids. So they were very often on multiple opioids, and all of them were on 200 morphine milligram equivalents or above daily. And you can see many of them were actually taking over 1,000 morphine milligram equivalents a day. So they took all of these opioids and converted them to buprenorphine monotherapy, right? And they checked in on them 3 months after they were converted to buprenorphine and asked them, how is the pain? And they compared the pain intensity when they were taking all of these opioids and 3 months after they were switched over to buprenorphine monotherapy. And it's just a 1 to 10 Likert kind of pain intensity scale. Higher the number, the worse the pain. And you can see that for all of these patients, including patients at the highest morphine milligram equivalents, the pain intensity decreased significantly on buprenorphine monotherapy, right? And certainly was a whole lot safer than whatever cocktail of pain medications they were on. So think about that. Also think about some of our buprenorphine formulations that are approved specifically for chronic pain, including the buprenorphine patch, the Butrans patch, right? Finally, in patients who may have chronic pain, opioid use disorder, severe chronic pain, naltrexone is probably not a great option, because if they're taking naltrexone, that pain management is going to be much harder to achieve. So I will stop here. It is, I think, 12:31. So